All right. Welcome, everyone. I'm Kimberly Dorris, Executive Director of the Graves' Disease and Thyroid Foundation. Our format tonight is all about your questions on Graves' disease and thyroid eye disease. We'll be covering a mix of questions that were previously submitted via Facebook, and then also some questions that come in tonight. If you'd like to ask a question, please use the Q&A function and not the raised hand, as that will hopefully allow us to collate everybody's questions and get through as many as we can. If we don't get to your question tonight, you can call the GDATF at 877-643-3123 or email us at info@gdatf.org, and we'll try to find an answer for you. This program is being recorded, and it will be available in the next few days on our website at gdatf.org and our YouTube channel, and I'll drop all of that contact information in the chat. So this program is a collaboration between GDATF and the American Association of Endocrine Surgeons. We're very grateful to the AAES and to all of our expert panelists and moderators for joining us tonight. Before we begin, just a quick reminder that our panelists and moderators are unable to give medical advice, so we'll be covering questions of a more general nature. And with that, I will turn things over to our two moderators.
Great. Thanks so much, Kimberly. We really appreciate this opportunity. I'm Lilah Morris-Wiseman. I'm an endocrine surgeon at Johns Hopkins, and I chair the Patient Advocacy Committee for the American Association of Endocrine Surgeons. Dr. Lim?
Hi, thanks. Yeah, my name is James Lim. I'm an endocrine surgeon in Portland, Oregon at Oregon Health and Science University. And yeah, happy to be here.
Great. We'll just have the panelists introduce themselves. How about Dr. Cooper?
Hi, good evening. My name is David Cooper. I'm an endocrinologist at Johns Hopkins, and I want to thank the Graves' Disease and Thyroid Foundation and the moderators for inviting me to speak to you this evening.
Great, thanks. Dr. Carneiro-Pla?
So I'm Denise Carneiro-Pla. I'm an endocrine surgeon here at the Medical University of South Carolina, and I'm a section chief of endocrine surgery.
Great. And Dr. Kazim?
Yes, good evening. Thanks for the invitation to be part of this. My name is Michael Kazim. I'm an oculoplastic and orbit surgeon at Columbia University in New York.
And Dr. Long?
Thanks so much, guys. My name is Kristin Long. I am an endocrine surgeon here at the University of Wisconsin in Madison, Wisconsin, and appreciate the opportunity to answer questions and chat with you all.
Great. So I think we can get started, and Dr. Kazim is really stepped in last minute to answer some expert questions, so it's going to be here only for the first part. So maybe we'll start with him. There were a lot of questions we received from the GDATF membership about the natural history of thyroid eye disease and whether it may improve on its own, the impact of thyroidectomy on thyroid eye disease. So if you could just talk about thyroid eye disease in relation to timing of thyroidectomy, whether it's expected to get better or worse, we'd appreciate it.
Sure. Those are both really important questions, and they really speak to the heart of how we approach these patients, right? We all are familiar with, or we're focused on, those patients with the worst eye disease, the most intractable cases for sure. But I think it's important to recognize that the overwhelming, and I want to repeat, the overwhelming number of patients are in fact ones that will improve spontaneously, and many of them will improve completely. So that when we talk about this disease, we sort of have to begin to understand as best as possible some factors that can predict the bad outcomes, right? So if we can pick those people out, we'll know who better to treat. But just from the get-go, one patient should not expect to fall into the really bad case, and anticipating improvement is something that we should do. We can talk about that more in depth, but just to get to your second question about the timing or the role for thyroidectomy, I think there are actually probably two ways of thinking about that. Number one is when should thyroidectomy be considered, and what improvements, if any, can one anticipate? Let's take the second one first, because I think this is a question that comes up periodically. I've been doing this for over 30 years, and about every decade, the question arises, does thyroidectomy have a have a salutary effect on patients with thyroid eye disease? And there's a logical connection between removing the biggest organ of immune attack, i.e. your thyroid, and perhaps some re-regulation of your immune system. However, I can tell you from anecdotal experience and generally the data that exists, there really isn't a great connection in that regard. So a patient should not anticipate that the way to treat their eye disease is to get rid of their thyroid gland surgically. That being said, I think that there is a significant role for thyroidectomy, and I would allow the endocrine folks here to speak more in detail. But from my perspective, when the decision comes, should a patient receive radioactive iodine or thyroid surgery as an alternative to medical thyroid treatment, I think in those cases where you have active ongoing thyroid disease, that consideration should be very seriously undertaken as an alternative to radioactive iodine. And it's a question that comes up not infrequently.
Great, thank you. Next question, I think we'll move on to Dr. Cooper, our endocrinologist. Dr. Cooper, can you talk about the long-term use of methimazole and how thinking has changed prior to where before we stopped treating, with medications of 2 years and we're leaning more towards something more definitive. Now I think, that thinking has changed, and who is most likely to benefit in terms of remission rates, and how should we approach this medically?
Well, when you think about it, it's amazing that surgery, of course, is the first treatment that was devised for the treatment of hyperthyroidism. This is back at the turn of the 19th century, early 20th century. And then radioiodine and antithyroid drugs were introduced in the 1940s. So there's really nothing new to treat Graves' disease other than the 3 treatments that we've had for, at least 80 or 90 years. And for a while, radioactive iodine was the predominant treatment for Graves' disease in the United States and much of the world. Surgery was never a major choice for people just because of its invasiveness. But radioiodine and antithyroid drugs were the 2 main treatments, and radioiodine predominated over antithyroid drugs. But then beginning in the 1980s and 90s and now into the 21st century, this has changed, and even radioiodine now is a very minor player in the initial management of patients with Graves' disease. And studies have shown that the popularity of antithyroid drug therapy as the main treatment has skyrocketed over the last couple of decades. And now, in terms of the choices that patients and doctors make, show that probably 80% of patients who have new onset Graves' disease are treated with antithyroid drugs as the first treatment. And radioiodine is a distant second, and surgery still is a third choice. Why this is not known completely, but in studies that have been done where patients have been asked about their choices, the main reason for rejecting radioactive iodine nowadays is the idea that some patients will go into remission and not have to be on any medicine at all. And of course, if you've had radioiodine or surgery, you'll have to be on thyroid hormone replacement. So remission is the hope that people have. So in some cases, it's probably a false hope, but for many people, remission remains a distinct possibility. And then there's the risk of worsening thyroid eye disease, which is a definite problem for radioiodine, especially in people that already have eye disease. But even in people that don't have eye disease, radioiodine can precipitate it or worsen it. It can be this worsening or precipitation. The worsening certainly could be prevented in some cases by treating people with steroids or the prednisone for a few weeks after the radioiodine. But that is one fear that people have. And then there's also been studies suggesting that people who've been treated with radioiodine may have a higher frequency of certain cancers later on in life. This is controversial, but there are studies that suggest that the risk of solid tumors like breast cancer, colon cancer, may be slightly higher in patients who are treated with radioiodine. So there's been this dramatic shift, not just in the US, but all over the world, toward antithyroid drugs being the major treatment for the initial management of patients who have Graves' disease.
Thanks so much, Dr. Cooper. Dr. Kazim, what is your experience with Tepezza? What side effects do patients have? Do they have lasting success? Will insurance cover it? Those are the main questions patients want to know.
That's a broad question. So, now we've had a good 3-4 years of experience with this drug. As with any new drug, there's a great deal of excitement that comes with the promise of its performance. But after several years, we have a much better understanding of where this might begin to fit in the choices that we have in terms of therapeutics. The drug does reduce inflammation. It does reduce swelling. It does reduce proptosis. And those are all encouraging. The claims as to how it improves double vision are less firm, in that patients can sometimes have improvements in double vision, but they still have lasting double vision. So that's, from my perspective, that is not a particularly helpful feature. There are two things that trouble me and many of my colleagues in the field. Number one is that there is a significant risk of hearing loss, in addition to other concerns of hair loss in younger women, infertility, at least that's temporary. There are and muscle aches, but hearing loss that occurs in at least 10% of patients. That number is higher amongst those who are older or have pre-existing hearing loss, and this hearing loss is permanent. So you need to wear a hearing aid if you are suffering this problem. Just had a lady in the office that I saw in second opinion yesterday. So that's one big problem, and there are reasons for it. And then the second one, which is probably even more troubling to me, is that the relapse rate, the recurrence rate of all of the symptoms, sometimes worse than the first round, will exceed 50%. So even if a patient is encouraged by the benefits of their treatments, and they don't have side effects that are disabling or permanent, they have a 50% chance of relapse. And that's actually even a more complicated problem, because it doesn't happen immediately after the drug is stopped, as occurs with prednisone. You give patient prednisone, the swelling goes down, you take the prednisone away. Within 2 weeks, if there's going to be a relapse, you'll see it. But in this case, the relapse can occur most commonly between 6 months and a year, sometimes a year and a half. So for those patients who are awaiting rehabilitative surgery after their Tepezza, because they still have double vision, they still have bulging, they still have lid retraction, we're now faced with an extended period of time when we wait to see if the relapse will occur, and then how to treat that is another complication. So I think that while we were all excited about this opportunity, I don't think it has, in my mind, the shine that it did 4 years ago, and that it is just another method of treating. In my experience, insurance companies pay for that drug for the most part, but that's really not. We need to look at other agents, and there are others out there, and there are more coming down the pike. So I think we need to look to the future, and if you'd like, we can speak about alternate treatments, but that's my thought on Tepezza these days.
Thank you. I think we'll ask Dr. Long the next question. Dr. Long, can you speak to some of the, I guess, what patients should be expecting in terms of surgery? How do you counsel patients in terms of, Graves' disease, thyroid surgery versus others? How quickly they will feel better, how long they need to be off work? Can you tell us a little bit about that discussion that you have.
Yeah, for sure. I think that obviously I have a bias as a surgeon, and that when I see patients with Graves' disease, typically we are talking about proceeding with something like surgery. I tell them essentially the risks for thyroidectomy and Graves' disease are the risks for thyroidectomy in any disease process. And the three things that I want to make sure everyone is fully aware of are the risks of bleeding, which typically is not concern about blood loss in the operating room, but more post-operative bleeding. We send almost all of our patients home same day, so I'm usually counseling them and their family members about looking for something like swelling or trouble breathing the night after surgery. Exceptionally rare, but exceptionally potentially high consequence. So we do a lot to talk about that. We always talk about things like issues to the recurrent laryngeal nerve, which is the nerve to the vocal cords and runs right up behind the thyroid gland. I do all of my surgeries with a nerve monitoring tube, and we talk about how that affects how we make our decisions during surgery. We talk about issues with potential, voice changes after surgery, some which are temporary, occasionally could be permanent. And then what I think is probably one of the bigger challenges in Graves' disease, which is the potential for temporary or permanent parathyroid and calcium problems. The thyroid is often enlarged, inflamed, really angry in Graves' disease, which is what does make the surgery, I think, technically a little bit harder and theoretically can increase some of those risks. So we talk a lot about how we try to prepare in advance. We do a lot of preoperative protocols to help minimize our risk of things like parathyroid problems. I talk a lot about if we inadvertently have to devascularize or take out a parathyroid, how we put that back in as sort of a safety deposit in an auto transplant little pocket in the muscle, trying to minimize risks of anything being permanent. And then we talk a lot about just deciding, who should be the person to do your thyroid surgery. I think it's incredibly important that patients ask their surgeon not only how many thyroid surgeries they do a year, but how many specifically they do for Graves' disease. We've got literature in our specialty that shows you probably should have somebody doing at least 50 thyroid operations a year to be considered really high volume, and therefore potentially lower risks for you as a patient. But you want to really make sure you have a relationship and trust with your surgeon that they do a lot of this and they're comfortable managing it. So we try to go through all of that and then decide what's the best option for this patient. And I think at least in our institution, we have a really high volume of patients seeking surgery. And for our specific institution, I would say about 60% of patients who are diagnosed with Graves' disease go straight to surgery after initial treatment with anti-thyroid drugs to get as close to normal thyroid function tests as we can get. And then we're able to safely take them to the operating room and do a thyroidectomy.
Great. Thanks so much for highlighting all those important points. We'll go to Dr. Carneiro-Pla next. There were a lot of questions related to pregnancy and Graves' disease. A lot of young women who are considering pregnancy or trying to figure out how to manage Graves' disease during pregnancy or pre. Can you talk a little bit about what people should be considering and kind of what thoughts about treatment prior to getting pregnant or treatment during pregnancy?
So I feel like maybe an endocrinologist will be the best. Dr. Cooper likely will be the best person to say how to prepare the patient when you are pregnant, you have Graves' disease, which drugs are best. PTU is a safer drug when you have Graves' disease and you are on methimazole. You should be, and I don't know if Dr. Cooper agrees with that, but move to PTU because it's a safer drug, especially in the first trimester. And you have to have blood work periodically and often, initially when you have Graves' disease and you get pregnant. Now, if you have Graves' disease and you're planning to get pregnant, I think that's the time that it's an ideal time for you to address your Graves with the definitive treatment, either with radioactive iodine. I'm not sure what Dr. Cooper feels about that. If you do get radioactive iodine, you need to wait at least 6 months to make sure that you get pregnant. You have to get your levels well controlled before you do that, because hypothyroidism is also a problem when you get pregnant, and so is surgery. If you have surgery, you need to wait until your antibodies come down. In a couple month, weeks, your levels will be much better, and you will better control from your thyroid function. So there is a period of time when you get treated, your definitive treatment for Graves' disease, that you need to wait until you can try pregnancy. But I think going into trying to get pregnant when you have Graves' disease, one of those two treatments is best. Then continue with your PTU or methimazole, and then hope that you will be able to control that. I don't know what Dr. Cooper feels about that. That one of those treatments, is better than going with just antithyroid medications. What do you think, Dr. Cooper?
Well, I think I agree with much of what you said, that if a person is on an antithyroid drug, most people are taking methimazole, that can cause birth defects. And so if a person is taking that, they could be switched to PTU, the other drug, but that also causes birth defects, although they're not as severe as the ones that methimazole causes. And that's why many women who have significant hyperthyroidism, although well-controlled, let's say, on methimazole, opt to not go on the other drug, but have some definitive form of treatment. And most people in that situation, in my experience, want to have surgery because they don't want radioactive iodine, because they have to wait many, many months. Also, there's this natural fear of radioactive iodine that people have nowadays. I don't agree that you have to wait till the antibodies come down after the surgery, because they go down as soon as you get pregnant. So pregnancy itself makes the anti-TSH receptor antibodies go down. And you could say, well, why do we even care? Because the woman doesn't have a thyroid, but the antibodies can cross the placenta and cause hyperthyroidism in the baby. But as I said, pregnancy itself is an immune suppressing sort of situation. So the antibodies go down very quickly when someone gets pregnant. So I think if someone has surgery and they go on levothyroxine replacement therapy, and then it's 6 or 8 weeks later and their thyroid tests are normal, it would be fine for them to go ahead and get pregnant.
Right. It's important to know how your surgeon will be doing this procedure, because if a lot of thyroid is left behind, which some people unfortunately still do less than a total thyroidectomy, if you still have a lot of thyroid tissue, your antibodies may not go low. And I had one patient that maybe shouldn't be talking about this, but had a little bit of perimeral lobe, and the antibodies actually stayed higher than I expected. And I never made a point about waiting, right? So you can try to get pregnant right away. And the antibodies were high, and the baby did have hyperthyroidism, which I was surprised. I never asked patients to wait. And I think the small perimeter lobe may have done that, but some people actually leave more thyroid tissue than others. I try not to leave anything behind, but some people do. And I think that's something that may be a caveat for people that want to get pregnant right away. I never measured, never recommended measuring, but
that we were having surgeons like Dr. Long, who is an experienced thyroid surgeon. So if someone has Graves' disease and they're going to have a thyroidectomy, they're going to have a near total thyroidectomy. That's the assumption we're all making.
Right.
If you say some surgeons leave a little bit of thyroid behind, those are not experienced thyroid surgeons.
Yeah,
So
unfortunately, a lot of the surgeries are not done by surgeons that are experienced. So for the patients listening to us here, it's very important that you do your research and make sure that your surgeon does a lot of these. Otherwise, we see this all the time. Patients come back to our clinic with pretty large remnants of thyroids that now we have to deal with it, So it's very important that you do your research and find a surgeon that can actually remove your entire thyroid.
I think that's really important. And studies you can correct me if I'm wrong, but studies have shown that up to 80% of people in this country who have a thyroidectomy have it done by a non-expert thyroid surgeon. Correct. Just a general surgeon in the community who is doing the thyroid one day and doing an appendectomy the next day.
Correct.
And that's not the kind of person that you want to take your thyroid out.
Correct. So yeah, and likely this audience will be an audience that will be doing their research before a thyroidectomy, but that's very, very important to make sure that you will have the result that you are trying to accomplish. And timing, especially for patients that are older that would like to get pregnant soon, the less time you waste waiting. So surgery is definitely a good option for patients with Graves' disease that would like to get pregnant. I don't know if your surgeons have anything else to add to it.
No, I totally agree with what you guys have said. I think that This is, there are thyroidectomies that I think can be done by general surgeons, but in general, Graves' disease is not the one I would want somebody that is lower volume to do, just because it is a technically harder operation. And I think, even for patients who are pregnant, patients who may be thinking about it, I think one of my partners gives the best analogy I've heard in terms of trying to decide between something like radioactive iodine and something like surgery, which is you can have kind of concentrated misery or you can have some prolonged misery. And surgery tends to be the concentrated misery. You get everything done in a relatively short period of time. Complications are thankfully pretty low. If they're going to occur, we usually know about them within the first 24 to 48 hours after surgery. And then can manage that as necessary. It's just, and then versus like radioactive iodine where you're dealing with it for several months, even to 6 months up to a year. So it's just a longer, more drawn out process, which is something that works, for some people that works better. For others, they sort of say, I'd much rather just have surgery and be done.
It depends where you're willing to put a risk, right? The risk and benefits of each procedure, right? For some singers, surgery is not a very acceptable way to treat hyperthyroidism. But if you're not a singer and you don't speak for a living, a public singing or a theater, surgery is a very good option for treatment of Graves' disease. Patients with gastric bypass are very high risk for patients having a total thyroidectomy for Graves' disease. So those patients, maybe radioactive iodine is a better option. So it depends. Every patient has their different indications. If you have thyroid nodules, surgery is a better option than if you don't have nodules, if you just have a thyroid that is not very large and have no lesions. So everybody's a little different.
Great, thank you. Dr. Cooper, I feel like we can't hear you. It looks like you're unmuted, but.
No, I'm not.
Oh, there you go.
Could you hear me now?
Yes.
Okay, I'm sorry. Why is gastric bypass a contraindication to thyroidectomy?
So it's not a contraindication, but the parathyroids, as you know, they get damaged very often on those patients. And even if you transplant them, those parathyroids, in my opinion, in my experience, they never raise to the occasion. So these patients often need PTHs of 150, even though they have normal vitamin D. And these parathyroids often don't get to that. So you may have a patient with a PTH of 70, and now the calcium is 7s and 8s, and they still need to take a good amount of calcium, even though your parathyroid hormone is normal. So the patients with Whipples and gastric bypasses, the temporary or it can be permanent, even though they have normal PTH levels. So the parathyroids that get transplanted just don't raise to the occasion. Do you surgeons agree with that?
Yeah, I typically tell people it's anybody who I think is going to have a calcium absorption problem, the risks of hypoparathyroidism are inordinately higher and much more severe. So I tend to look at it's not exclusively if they've had a bypass, it's how successful was this bypass? Are they on calcium supplements now? Do they already have some secondary hyperparathyroidism? Those are patients that surgery is much, much higher risk. And, the consequence of something like hypoparathyroidism is much more severe, up to the point that it could be lethal. So we just want to make sure that we're not putting them at undue risk.
So some of these patients are crippled by that complication, even though their PTHs are totally normal. So patients like 3, 4, 5 grams of calcium with a PTH of 70. So those are definitely considerations when you decide to do the thyroidectomies for Graves.
Great, thank you. I think another example of why experienced surgeons need to be kind of managing and so that they can go through all these different factors. I wanted to ask Dr. Kazim one last question before he has to leave, but there was a question from the chat. Are there any treatments for mild thyroid eye disease for people who are maybe not advanced enough that would benefit from surgery or Tepezza? I think they were wondering specifically about supplements or possible off-label drugs, or or if you have general recommendations for patients, just with dry eyes from thyroid eye disease in general.
Sure. In my first consultation with a patient, my objective is to determine, obviously, if they have the right diagnosis and the severity of their disease. I mentioned it earlier. that trying to get an understanding of the severity of the disease tells me how and how much to intervene on their cases. So the mild cases may come in mild, but they may have those dispositions that make them likely to ultimately become severe. So just as an example, those are older patients. They tend to be male smokers. We think that people with obstructive sleep apnea are also in that group. Diabetics, people with high TSIs. And what is also important is how quickly they are getting worse. So patients who come to me at 6 months into the disease with just a little bit of eyelid retraction are far less likely to progress, require far less attention as an intervention than the patient that shows up to me at month 1 and they already have a significant amount of lid edema and their muscles are stiff and they may have early double vision. These are folks that I need to separate. So again, while a person might be mild when they first show up, I need to predict as best I can who's going to get bad, intervene early, suppress their disease. We just published something recently to resort how we begin to consider the therapeutic armamentarium, but we need to decide when to employ measures that suppress their disease, preventing it from progressing, and when to employ those drugs that might suspend the disease early. And that makes it a very complicated process, but it's an important one for people in this field to begin to think about a little bit more carefully when we consider our patients. But to the point of a patient who is mild, those are typically considered those patients who have some lid retraction, dry eye, and redness. And those patients benefit, as was suggested, with some form of topical lubrication. And that also reduces the suspended inflammatory cytokines, those proteins in your tear film that actually make your eyes irritated. The use of supplements, selenium has been shown in mild cases to have benefit, and that's especially for those patients who have a deficiency of the mineral selenium, and the supplement should be probably limited to 200 micrograms of selenium daily, or 2 Brazil nuts provide the same supplementation. Patients should, for certain, again, the modifiable risk factors: don't smoke. If you have sleep apnea or the risk of it, get tested, get treated if that's the case. Reduce the salt in your diet so that the edema doesn't pool in your eyelids. And be monitored at an appropriate interval so that if one begins to diverge from the mild case, then they can be treated. Off-label drugs, they certainly are. And the one that has been very helpful to me is a drug called Actemra, or tocilizumab, again, an off-label drug used for rheumatoid arthritis, but it has been shown to be a powerful anti-inflammatory, probably more in the moderate group than in the mild group, but it's something that's worth considering with your treating doctor.
Thanks so much. We'll go to one of the questions from one of the members about COVID and COVID vaccine and Graves' disease. Dr. Cooper, I wonder if you could talk about, the question was that there have been a handful of case studies of new onset Graves following COVID vaccination, but also studies of new onset Graves after COVID infection. And increased risk of other autoimmune diseases post-COVID. What's your guidance on Graves' disease? What are your kind of thoughts about this, and COVID vaccination in particular?
Well, I think we'll all remember that when COVID first started and then the vaccines became available, there were these case reports of people having severe pulmonary disease who had to be hospitalized with inflammation in their lungs. There were people with heart inflammation and heart failure. Some were needing heart transplants after the vaccinations. And this led to a number of studies showing that after vaccination or after having COVID itself, there's just an increase in all autoimmune diseases, from rheumatoid arthritis to lupus to Graves' disease to low platelet counts to heart problems, inflammatory bowel disease. All of these things seem to be increased slightly compared to the background. Although, you know, these are just case reports, really. There are no controlled studies just looking at, you know, a placebo vaccine versus the COVID vaccine or something like that. So there's just this impression that as part of the vaccine's, you know, function and the way it immunizes you against the virus, and also just getting COVID itself in your own body, fighting the virus, this seems to heighten the immune system, and in some people who are probably genetically predisposed may, you know, lead to their getting some autoimmune disease. And one of those autoimmune diseases is Graves' disease. But it's not like there's this epidemic of Graves' disease after, you know, COVID or after COVID vaccination. It's basically just still case reports and series of, you know, 5 patients, you know, from some university where Graves' disease was diagnosed after a person got the vaccination or had COVID. So I don't think there's any change in the recommendation about the importance of getting vaccinated. And also, if you already have Graves' disease, then nothing bad's going to happen because you already have Graves' disease. And there's no evidence that getting vaccinated or getting COVID is going to make your Graves' disease worse if you already have it, or induce thyroid eye disease, for example, if you already have Graves' disease. So I don't think people really should be worried about this.
Thank you. We can go to Dr. Long. Participants want to know what questions they should ask their surgeons. Do you want to talk about this a little bit and kind of what guidance maybe the AAES gives, kind of what resources do patients have in terms of what they should ask when they go in for a surgery appointment?
Yeah, for sure. I think we've already covered probably the most important thing, which is simply asking, you know, how many of these surgeries do you do? What are your personal complication rates? And I always try to, if not asked directly, try to kind of explain my thought process on how I move through the operation. You know, if it's a patient, like we mentioned earlier, who maybe has some higher risk factors, I tend to go into a little more detail about what might happen if you have this particular complication and what you could expect along that journey. Patients always want to know more details about like the length of the surgery, the length of the recovery, what that post-operative period kind of looks like. And, you know, in general, as I alluded to, we send most of our patients home same day. There's a lot of institutions where people stay one night for observation, especially depending on travel time, how far you may be from the hospital, or how easy it might be to get back into the hospital if you did have a concern. I always go over with people that I generally ask them to take about a week off from work, because even though it can be an outpatient surgery, it's still a general anesthetic. It's still a trauma on your body. I'm still removing an organ from your body, and you're not going to feel great for at least a week or so. So I try to encourage people to take some time for recovery. It's also, you know, I think sometimes, especially we as surgeons, sometimes maybe underestimate the magnitude of the hormonal fluctuations of what patients feel as they sort of recalibrate and go from having hyperthyroidism to hopefully closer to normal thyroid function, even if it is on a synthetic pill. And people sometimes need some extra time just to, you know, recover and recalibrate from that. I also think it's really important for patients to kind of talk to their surgeons about anything that they might want to be doing preoperatively that might be helping to prepare for that. People want to know if they need to really have any like dietary changes or other medications. I think most surgeons and the AAES would probably kind of stick behind this in terms of doing some preoperative preparation, whether that's with calcium supplementation, iodine solution to kind of minimize risks of bleeding, or even what we've been doing a lot here at UW, which is preoperative prednisone to try to minimize some of that inflammation and then mitigate the risks that we're dealing with intraoperatively. So I think it's worth, you know, asking surgeons all of those things and making sure that you're comfortable with the answers that they are able to provide for you before committing to a definitive operation. Because, you know, once I always say we can change our minds up to the point of going under anesthesia and starting the operation. But once we start the operation, or if I take it out, I can't put it back unless it's a parathyroid, in which case I can put it back. But that's a topic for another day.
Great. Thank you, Dr. Long. I was going to ask Dr. Carneiro-Pla as well, just in terms of, what Dr. Long was mentioning in terms of preoperative preparation. You heard some of the things that Dr. Long does. I guess, what's your practice, or, what are other things that might be done?
So vitamin D deficiency is extremely common. I do not use calcitriol, which is a common practice. I think of a lot of our AAES members, they do calcitriol. I don't. I give ergo until vitamin D is at least 30. I don't check it. I do the 6 weeks ergo calciferol replacement and ask them to stay on 2000 after that. So make sure that they have a good vitamin D. And usually I have no issues in controlling the calcium post-op. And I use Lugol's or iodine drops, right, for the patients that have very severe Graves. So I do ultrasounds in all my patients. So if they have very angry Graves disease, very inflammatory changes, very vascular glands, which usually is the case with Graves, sometimes I'll give Lugol's. The ones that I have a lot of difficulty in controlling the thyroid function, along with my endocrinologist, and Dr. Cooper step in, I will give them Lugol's because it helps to control the thyroid function closer to the surgery, especially the patients that may not be very compliant with their meds. That is helpful to get their thyroid function under control closer, but I don't give to every Graves. The Graves that don't have a lot of inflammation, I don't usually give a Lugol's before the surgery. But I do not operate on patients that are toxic. They have suppressed TSH, as all the patients do, but I will always try to control the T3, T4 before surgery. The very few patients, usually due to compliance, that I took to the OR and they had elevated T3, T4, things don't go as well. And they bleed, not only intraoperatively, but on the mucosa. You try to put temperature probe and they bleed everywhere. So I really try not to operate patients with T3, T4 elevation. But TSHs, of course, they always suppress, but always control that, of course, with antithyroid meds, along with our endocrinologist to control them before. If they cannot take it, which, is not an uncommon problem, whatever it takes. We do the Lugol's I'll do usually 8 days before, steroids, whatever it takes, but I don't operate on toxic patients. That's mostly what I do in preparation for patients with Graves' disease. I do not give them calcium pre-op. If they have signs of bone turnover, and they have high PTH, I will try to treat that, but and most of the time they don't need calcium pre-op, mainly vitamin D replacement. Anything else you guys do differently? I think calcitriol is something that people do very often before surgery. I do not do that.
Yeah, there's a study on calcitriol before we do calcium. We actually do 10 days of calcium pre-op.
Calcium and calcitriol?
Just calcium, we do.
Yeah. With vitamin D replacement above 30, I don't have a lot of issues in controlling them postoperatively. Now, if they're deficient, yeah, those are hard. But if they're well replaced, I don't feel like it's difficult. Dr. Cooper, anything you want to, that preoperatively, sometimes it's hard because they cannot take the antithyroid meds, and to get them euthyroid is difficult. But, and some surgeons are operating on patients that are toxic. I don't feel comfortable in doing that. I know a lot of people do. I do not do that.
Well, as you know, there's some patients who are allergic to antithyroid drugs,
Correct.
so they can't be made normal before surgery. We try hard to, give them certain drugs called styramine and iodine, but some patients just go to the operating room hyperthyroid. And back in the day, I'm talking about the 1970s and 80s when beta blockers were first introduced, there were many surgeons all over the world who treated patients with beta blockers and SS and iodine, and patients went to surgery still hyperthyroid, and they did fine. So we don't do that anymore because, we think that being euthyroid is better, but there are studies that suggest that people who go into surgery hyperthyroid, not that I'm advocating this, but I'm just saying it may turn out to be okay for most patients. We don't, and that's why I'm saying sometimes we can't. Dr. Morris-Wiseman and I had a patient a few weeks ago who was just the most thyrotoxic. He was hospitalized for his thyrotoxicosis. He could not be made normal, no matter what we did. And he went to surgery with her flagrantly his free T4 level was higher than that could be measured. And he did fine. He went home 2 days later.
I'm sure you had fun.
Thanks
Lilah.
to you. But anyway, I'm just saying sometimes you
Yeah.
have to operate on somebody even though they're not normal.
Yeah. Yeah, you
Yeah.
know, there are things that you can, you know, that you can try and give. Definitely a surgery is definitely harder if they are hyperthyroid, I feel. Don't you think, Lilah?
Yeah, I think it can be a lot harder. I think there's a balance. Dr. Cooper calls me and tells me, I really need you to operate on this patient. You know, I think there's a balance. I think we have to be careful and thoughtful, but also we can't be scared. You know, we can do whatever we can do and have a frank discussion with the patient and the family to say, here's what I'm concerned about. Here's what might happen. You know, and sort of just go from there. But I think just a frank, honest discussion, but not doing, I think the point is not doing things kind of willy-nilly, but being, you know, focused and thoughtful about it.
For the
So.
patients watching, right? So one thing is, I think is important is logistics. So I always tell my patients, if your endocrinologist change your meds 2 weeks before surgery, you could go hyperthyroid right before your surgery. It's not because you cannot be controlled, it's because your meds were changed too close to the procedure. And if we don't know about it, we cannot measure and make sure you're fine. So sometimes there's some disconnect between the two worlds, you know? So it's always make sure your surgeon knows that your medication was changed. So we have time to measure your function before the procedure is done. That's something I do. I'm not sure if everybody feels the same, but I always ask my patients, if your medications was changed, make sure you let me know. So I have time to check your function before surgery if it's close enough. There's some things useful for the patients.
Great. There was another another question in the chat for Dr. Kazim. I guess, Dr. Kazim, can you speak to the success rate of strabismus surgery in correcting double vision? And, you know, I guess, do people get multiple strabismus surgeries? You know, this is what's being asked in the chat. I don't know if you can speak to that.
Yeah, it's a good question. I do a lot of strabismus surgery in these cases, and they are among the more challenging muscle procedures. However, with the assistance of an excellent orthoptist, that's a technician who measures eye muscle balance in a dozen fields of gaze and at different distances, you can really gain some understanding of which muscles to operate on, how much to operate on these muscles. With that in mind, if you have double vision that's side by side, horizontal, you should expect a 90% success rate. And if you have vertical double vision, there's technical reasons why it's more challenging, but you should have about a 75% chance of single vision with or without a very small amount of prism. And that's defined as so little prism, you can't even see them in your glasses. And if that fails, then another operation typically is all you need to resolve the residual double vision. So those are the numbers that we've generated. I'm looking at the question, and then there's a second part to the question, which is actually hard, which is this person has completed 8 infusions of Tepezza, they've waited 6 months, and now they're considering surgery. Is it safe? And that's an unknown question. That is one that baffles us to this day, because we now have cases where relapses occur on average about 6 months, certainly not uncommonly at 12 months. But really, unfortunately, at 1.5 years to 2 years, we've seen single cases. So that's the challenge. Do you choose to operate at 6 months, 1 year, or 1.5 years? No one really knows the answer to that question, and we're looking into it. Unfortunately, this is a delay in trying to get to the treatment that this patient needs. It's a good question.
Great. So there were, do you have to, you're going to log off?
Guys, I much appreciate your invitation to be part of this. I really enjoyed it. Have a good night, everyone.
Thanks so much. So we'll go over to Dr. Cooper, and there were some questions, multiple questions about medications. And so I'll summarize a couple. Several questions really, we'll give you a list here. Several questions related to T3 and whether preservation of some thyroid with Graves may be beneficial. I think we already sort of answered that. And then whether combination therapy post definitive therapy with Graves is helpful, Cytomel or Armour Thyroid. And then a couple other questions about new anti-thyroid drugs coming down. And I think those were the major medication type questions.
Well, one of the big controversies in thyroidology is whether some patients who don't feel back to the way they used to feel after they have a thyroidectomy or after radioactive iodine might benefit from T3 therapy in addition to the T4 or levothyroxine therapy that they're already on. And the reason that people are raising this issue is because normally T3 is the main thyroid hormone that actually regulates your metabolism. It's not T4. T4 has to be converted by your body into T3, and it's T3 that mediates all the metabolic functions of thyroid hormone. Now, in a normal person, 80% of all the T3 that comes about in your body every day comes about from the removal of an iodine atom from T4 to make T3. In fact, T4 is called T4 because it has 4 iodine atoms, and T3 is called T3 because it has 3. So your body removes 1 iodine from T4 to make T3. But about 20% of your T3 arises from in your body every day from your thyroid. So if your thyroid has been removed, where does that other 20% come from that you're now missing? And the answer is it may not come from anywhere. In other words, your body doesn't automatically start increasing the deiodination of the T4 pill that you're taking now to make more T3. And it's been shown in many studies that after a total thyroidectomy, the T4 levels in the blood on your levothyroxine, when your TSH levels are normal, so you're like a normal person now, the free T4 levels are higher than they used to be preoperatively, and the T3 levels are lower than they used to be. So most people who take levothyroxine have a lower T3 than they did before they had their surgery. And I'm not even talking about Graves' disease. Let's say a person who just had a thyroid nodule, they had their thyroid removed, so they didn't even have a thyroid abnormality in terms of the function of their thyroid. Their T3 is lower than it was before they had their surgery. Now, most people, fortunately, feel fine. But there is a subset of people, maybe 10 to 15% of people who have a thyroidectomy, and then on their levothyroxine therapy, when their thyroid function tests are completely normal, don't feel the way they did before they had their surgery. They have fatigue, or they've gained maybe 5 or 10 pounds, and they have no IDOI. Or there's another term that people use a lot called brain fog, where you can't concentrate or just have trouble thinking. And there was a study that suggested that these symptoms might be improved by supplementing with T3. But subsequently, this study was published in the New England Journal of Medicine about 20 years ago now. Subsequently, there have been a dozen randomized controlled trials with placebo controls showing that when people are put on combination therapy, they actually don't feel any differently than when they're on a placebo. So this has led to a questioning now of whether this is something is a benefit or not. And the problem is that in these studies, all of which have been done very carefully by scientists who know how to conduct trials, they didn't recruit people who didn't feel well in these studies. They just recruited everybody who were taking levothyroxine, and some of them, there's some period of time they were on placebo and some on T4 plus T3, but they didn't exclusively study people who didn't feel well. So we still, I don't think, know the answer to whether some people might feel better taking T3. So in my own practice, if somebody has a thyroidectomy, let's say Dr. Morris-Wiseman does a thyroidectomy on a patient and they come in to see me, their thyroid tests are completely normal now on their levothyroxine, and they are fatigued, they are, just not feeling exactly the way they did preoperatively. I don't have any problem trying T3 in such a patient. And it used to be that people who did that, like me, were considered, kind of crazy and outside the realm of medical practice. But now it's being more accepted to do this. And so that's what I would try, but kind of as a therapeutic trial. I mean, I would say to the person, let's try this. If you don't feel any better in 3 to 6 months, then there's just no point in taking it. And honestly, in my experience, some people do feel better. Some people don't feel better. Some people feel better and then they don't feel better. Some people even feel worse because they develop hyperthyroid symptoms on it. So, but anyway, I think it's worth a try. The whole idea of the armor thyroid or desiccated thyroid, this is, thyroid glands, thyroid hormone or thyroid extract taken from pig thyroids. And the idea there is that pig thyroids, like human thyroids, have both T4 and T3 in them. So when you're taking the desiccated thyroid, you're getting some T3 in addition to the T4. But the problem with the animal thyroid extracts is that the FDA does not regulate the amount of hormonal content in these pills the way it should be. The manufacturers don't really can't tell us precisely how much T4 and T3 is in an Armor thyroid pill or Nature thyroid pill or any of the other pills that you might see. So if we're going to do it, I prefer that the person be on levothyroxine plus T3, or it's called Cytomel is the brand name for that. Oh, as far as new treatments down the pike, yes. As I said, the treatments we have are the treatments that, your grandparents had. There's nothing new. But there are treatments, just like the treatment for thyroid eye disease, the teprotumumab or Tepezza, there are treatments that are being developed now that are probably going to be able to get at the autoimmune cause. They can block the receptor, they can block the antibody, they can do other things to the immune system that, just like the new treatments for rheumatoid arthritis or psoriasis or ulcerative colitis that you see on TV in commercials all the time, they are working on treatments like that for Graves' disease. And I predict in the next 5 to 10 years, we will have drugs that can specifically treat the immune problem and not poison the thyroid with antithyroid drugs or remove it surgically or radiate it with radioiodine, these are all just treatments that poison the thyroid or get rid of it. There might be treatments that get at the exact cause, maybe in a few years.
And I think we'll about at the time to wrap up. This has been a great discussion. I know we didn't get to all of the questions. It was a lively chat, but thank you so much, Kimberly, for having us. And I'll let you wrap up.
All right. Thank you so much. Again, if we didn't get to your question, you can reach out to us at 877-643-3123 within the USA and Canada. You can email us at info@gdatf.org. A quick note from a question in the chat about long-term use of antithyroid drugs. We actually did a very deep dive a few years ago with Dr. Cooper and Dr. Eve Bloomgarden on long-term use of antithyroid drugs. And that's on our YouTube channel at Graves and Thyroid. And it's one of our most popular programs. It's getting close to about 10,000 views. So thank you, everyone, for joining us tonight. Thanks to the AAES for their commitment to patient education. A huge thanks to our panelists and all of our moderators who have donated their time tonight. We appreciate all of you so much. Thank you and have a great evening.